Warm greetings from Kasturba Medical College and Hospital, Manipal, Manipal Academy of Higher Education, India. Myself, Dr. Kavita Sarao, Professor and Head, Department of Infectious Diseases, and the organizing chairperson of this conference, have the pleasure to invite you all to the 4th day of International Conference on Antimicrobial Resistance, Combating the Same. This conference has been organized. Today's program has been organized by the Department of Infectious Diseases and Manipal Center for Infectious Diseases. Critical illness and antimicrobial resistance are the deadly duo and can be devastating. Critical illness patients have multiple comorbidities and the treatment outcomes are still poor. Can individualized dosing of antimicrobials overcome these limitations? Also, the theme of the World Antimicrobial Awareness Week is Antimicrobials Handled with Care. While we strive to give right antibiotic earliest to the patients who are critically ill, it's elemental to prevent overuse of antibiotics. This is the balance which every clinician must strive to practice. So today's 2 lectures, I'm sure, is going to throw light in this direction and educate all of us much better. I have the pleasure of introducing today's moderators, Dr. Vishal Shanbag, Critical Care Physician at Kasturba Medical College, Manipal, and Dr. Jairaj, Professor and Head of Department of Emergency Medicine at Kasturba Medical College, Manipal. Over to you for taking over the proceedings. Vishal and Jairaj.
Good afternoon, madam. Thank you for the kind introduction. So we'll come to today's first session, drug dosing in the critical care. It's my pleasure to introduce Dr. Jason Roberts. So he's a consultant clinical pharmacist at Royal Brisbane and Women's Hospital, Queensland. He also serves as a research chair for University of Queensland Centre of Clinical Research. He's a clinician scientist with a strong interest in research in principal research theme in optimization of antibiotic dosing in critically ill. He had been awarded more than 30 million grants for research, and he published over 450 papers and books and lot of books in the chapters in the books. Currently, he supervises around 22 higher research degree students. He has served on the critical care review panel for ATS and IDSA guidelines for hospital-acquired pneumonia, healthcare-associated pneumonia and ventilator-associated pneumonia, and Australian therapeutic guidelines, antibiotics and 2021 surviving sepsis guidelines. He is editorial board of various peer-reviewed journals such as International Journal of Antimicrobial Agents, Journal of Pharmacy Practice and Research, the Journal for Society of Hospital Pharmacists of Australia, Pharmacotherapy and Anesthesiology, Pain and Critical Care Medicine Journal. So with this short, brief introduction, over to you, Dr. Jason.
Well, good evening, everyone. It's a pleasure to be here. I'm just going to share my slides. Okay, I hope that's coming through clearly now. So it's an absolute pleasure to participate in this meeting. I have really fond experiences of traveling in India and speaking to healthcare professionals about this very topic. And so I know that India is a big place, and so I haven't spoken to anywhere near as many as I should. So it's an absolute pleasure to accept this opportunity to talk to you about a topic which I'm really quite passionate about, which is antibiotic dosing in intensive care unit patients. And of course, this is a topic that aligns very well with the theme for World Antimicrobial Awareness Week, which is, of course, handling antimicrobials with care. And that's what optimized drug dosing is all about, personalizing drug dosing to the needs of the individual patient, taking care in the selection of those doses, just like we do in the selection of the drug itself. And as I hope that I'll be able to demonstrate to you throughout this presentation, is that if we are able to optimize the way that we dose antimicrobials, then we can dramatically increase the likelihood of a good therapeutic outcome for patients. And indeed, one of those outcomes may be the minimization of the emergence of drug-resistant pathogens. And so, again, that's very important for considerations of antimicrobial resistance in this important week in the healthcare calendar. So I've just got some disclosures that I'd like to make on this slide, just for your reference, but none of these are relevant to today's presentation. So these are the contents of what I hope to get through in the next 35 to 40 minutes or so. Firstly, to talk about why there are challenges with antimicrobial dosing. What is it about critically ill patients that make them particularly challenging for clinicians in aiming to provide the best possible therapy for them? And then to provide an understanding of why pharmacokinetics and pharmacodynamics, or PKPD, is so important to optimizing treatment in critical care. And in doing so, I want to go through three specific patient groups, or some characteristics which are associated with different treatment interventions that we can provide, and the effect that this has on drug dosing requirements. So to talk about augmented renal clearance, or ARC, renal replacement therapy, or RRT, and extracorporeal membrane oxygenation, or ECMO. And then to bring all of that information together to then talk about what the consequences of this new information that we have into a framework which we can use for better antimicrobial dosing for the benefit of our patients. So importantly, what we need to consider is why we need to individualize doses at all. Why is it that standard doses that are found in the product information for antimicrobials are inappropriate? And the rationale for that really comes from the fact that the registration trials upon which the dosing regimens that are found in the product information are based on a certain behavior of drugs in a certain patient population. So to explain this a little bit more, to understand what a drug dose is, to define what a drug dose is that should be used in patients, this typically starts in the laboratory, whereby in vitro studies or in animal studies, the exposure of an antimicrobial that's able to kill bacteria is defined. Once we know what that specific exposure is, some clinical studies are then undertaken, predominantly or initially with healthy volunteers, to make sure that those kind of exposures which were able to kill bacteria are actually safe and tolerable in humans, and so they tend to be done in healthy volunteers. And then by combining knowledge of the behavior, so the pharmacokinetics of those drugs in the healthy volunteers, with what exposures are known to be appropriate from the laboratory studies, some dosing regimens are proposed, and they are then taken forward into phase 3 clinical trials. And if there is a positive effect demonstrated of that drug in that scenario, then effectively those dosing regimens in that patient population has been appropriately validated. So when the dosing regimens aren't appropriate is when the behavior of the drug or the pharmacokinetics is different to the pharmacokinetics of the patient populations that are seen in registration trials. Why is this relevant to critically ill patients? Well, that's because critically ill patients are rarely considered as part of registration trials. Almost always they include patients that are in a ward-based scenario, are not obese, they will not have significant organ dysfunction, and they'll be quite homogeneous in comparison to the kind of patients that will then later receive that drug. And so this is an important justification for why we should be thinking about the patient population in who that drug, that dosing regimen has been developed. And I do want to pay credit to a lot of pharmaceutical companies who are making a bigger effort in these phase 3 trials to include critically ill patients, because they're obviously an important group. But as I mentioned before, patients with renal failure, liver failure, those that are obese, those with significant burn injuries or cystic fibrosis patients, those that may have solid organ transplants or receiving some sort of extracorporeal therapy, these are patient groups who are not studied commonly in those registration trials, and therefore there is an uncertainty about the appropriateness of dosing some of those dosing regimens in those patient groups. And that's why an understanding of pharmacokinetics of the drug is important. The other very important point to note about antimicrobials, which is quite self-evident, is these are not drugs which we can titrate to a measurable pharmacodynamic endpoint, and therefore can't intrinsically personalize the dosing to the needs of the individual patient. If we think about a vasopressor drug, whereby we can titrate dosing to a mean arterial pressure target, or a sedative drug, whereby we may choose to titrate the dose in an individual patient to a desired level of sedation, these are almost end of needle effects that we can be titrating dosing to, but we can't do that with antimicrobials. Looking for specific biomarkers or alternatively clinical markers of infection and trying to monitor for changes of these to give us a guide about whether our dosing is appropriate just isn't appropriate, because that can take anywhere from 24 to 48 to 72 hours. And if we're waiting that long to find out that our doses were appropriate, then that can be catastrophic for the patient. So importantly, antimicrobials, almost more than any other drug class, have a clear concentration effect relationship. Now, this is very clearly demonstrated in vitro studies and animal studies as well, whereby small modulations of the concentration of the antimicrobial can be shown to have dramatically different effects on the capacity of that antimicrobial to kill bacteria or to even prevent the emergence of resistance. When we think about this in the context of clinical studies, we know that it is not really ethical for us to conduct a study whereby we randomize a patient to a low exposure of drug versus a high exposure of drug, or a therapeutic and a non-therapeutic exposure of drug. And so most of our descriptions of a drug concentration target, which is associated with a better outcome, tends to come from observational studies where pharmacokinetic data has also been collected. And that's essentially what this slide is describing here. Importantly, you'll note that for almost all the different drug classes that we use in clinical medicine and in critically ill patients to treat severe infections, they all have an exposure of drug which has been defined to be associated with a better clinical outcome. Now, almost always this is done in the context of improved clinical cure, but in some cases it's done in the context of improved survival. And so again, this provides more evidence to us to support the fact that drug dosing is important. And if we can achieve particular exposures of drug, which will need a patient-specific dose to achieve that, then we can increase the likelihood of them having clinical cure and hopefully, of course, having a very good clinical outcome. So I wanted to draw each of your attention to this specific paper. Now, this is a position paper which our group was fortunate enough to lead and was published in the journal Intensive Care Medicine in October of 2020. But this is a position paper which was constituted of key opinion leaders from 4 international societies: the European Society of Intensive Care Medicine, the European Society for Clinical Microbiology and Infectious Diseases, the International Association of Therapeutic Drug Monitoring and Clinical Toxicology, and the International Society for Antimicrobial Chemotherapy. Each of those organisations contributed specific members to this group, who then worked on a position paper to define the importance of therapeutic drug monitoring. Now, although in this specific presentation we haven't got to that topic of therapeutic drug monitoring, this paper is very useful because it goes through the background about the altered pharmacokinetics and altered dosing requirements that are likely to be needed in critically ill patients, and so it has some important information in that regard. And then also provides a framework through which therapeutic drug monitoring or other PK/PD-based dosing approaches could be used. And so I wanted to spend a little bit of time reflecting on that paper and provide you with that citation. So next I wanted to talk about what some of the key PK/PD considerations are in critical care. So what is PK/PD? Okay, so it's pharmacokinetics and pharmacodynamics. Pharmacokinetics, as its own definition, essentially is the relationship between a dose of drug that's administered and the concentrations that are observed in the body. Pharmacodynamics, on the other hand, is the relationship between a concentration of drug and the effects, the pharmacological effects that it exerts. So pharmacological effects from antimicrobial are typically bacterial killing, but can also be considered in the context of suppression of emergence of resistance. So PK/PD itself links the dose of drug with some kind of endpoint. So antibiotics, as I mentioned previously, they have a very strong exposure effect relationship, and dosing that does not align with PK/PD will result in suboptimal effects because it won't achieve those exposures which are known to be associated with better outcomes for patients, or will certainly achieve those less consistently. And so although we spoke about this in the context of clinical failure in terms of an inability or insufficient bacterial killing and potentially the emergence of resistance, it can also lead to drug toxicity. And we see this quite frequently and traditionally with drugs like gentamicin and vancomycin, whereby inappropriate dosing leads to nephrotoxicity and ototoxicity. But we're seeing this increasingly with other drug classes as well, as we look for effects which are associated with excessive concentrations. And so for beta-lactams, there's a broader understanding of neurological worsening in these patients with very high drug exposures. And so this is why therapeutic drug monitoring, as one potential entity to improve the accuracy of dosing, has been mooted and should be supported, because it increases the likelihood of achieving optimal exposure, because you're measuring a concentration in that individual patient, and then you're choosing a new individualized dose based on information you have from that patient. So what is it about critically ill patients that makes dosing so challenging? What it really comes down to, from my perspective, is the spectrum of organ function that is possible in an intensive care unit. Now, I'm sure that all of the different participants on this webinar have been into an intensive care unit, and you've walked around an intensive care unit and have seen the wide range of patients that there may be throughout the unit, and how contrasting one patient can be in one bed versus a patient in the next bed along. So when I am working in a clinically and I'm trying to decide what kind of dosing regimens that we should be using for patients, I tend to quite crudely think about a graphic like this to try and categorize what kind of patient it is. And so if we think about these categorizations, we can have some patients that are very hyperdynamic. So this is the graphic on the far left side, whereby essentially they are responding to some sort of insult, which could be trauma, it could be infection, it could be a burn injury, pancreatitis, a neurotrauma, for example. And as part of that response to that insult, and before they've developed any end organ dysfunction of the kidneys and the liver in particular, they can become very hyperdynamic. And this will lead to an increased cardiac output. Now, that increased cardiac output, of course, increases perfusion of those eliminating organs, like the kidney in particular, but also the liver. But if it's a renally cleared drug and you're increasing the delivery of that drug to the kidney per unit time, then you will see increased drug clearance. And therefore, relative to other patients that don't have that same presentation, you'll see much lower drug concentrations. The next categorization along can be related to that group as well, but also can be related to some of the other categorizations and refers to the context of whereby patients have an altered fluid balance. Now, this is very common, of course, for patients that are unable to support their own blood pressure and require fluid resuscitation. That excess, that fluid that is provided those patients to maintain their blood pressure, often because of the presence of leaky capillaries, will cause an edematous state, whereby the fluid has leaked into various peripheral tissues. And what that can mean is that because we've given effectively an extra volume of water, which could be anywhere from 2 to 5 to 10 or even 15 litres in severe burn injury patients, this can lead to effectively a dilutional effect for drugs that are water soluble because there's more water present in the patient. And this then manifests as an increased volume of distribution because it aligns with those specific, that pharmacokinetic definition. If it has that dilutional effect, then of course that can also lead to lower drug concentrations. Of course, there can be some patients that don't have any organ dysfunction and therefore have effectively very similar dosing requirements to patients typical patients in a general medical ward or a general surgical ward. Then there are those patients that are more commonly considered in the context of critical illness. They're those patients that have a renal and or hepatic dysfunction. And typically those patients will have an increased volume of distribution, but decreased drug clearance because the drug isn't being removed as quickly. And almost always the clearance aspect is what tends to dominate the dosing requirements. And so even in the context of an increased volume of distribution, we'll tend to see higher drug concentrations if we use a renally, as if we don't adjust the dose properly. And then finally, we have those patients that may have an organ support requirement. So this is, I'm talking about renal replacement therapy or ECMO here. And these patients can have definitely an increased volume of distribution, but the effect of this on the clearance of the drug from the body is very dependent on the modality and the settings of those treatments which are used. And so that's why I remark here that it can have a decreased or an increased effect on drug concentrations. So at the moment, that schematic, that presents just a theoretical approach to considering altered pharmacokinetics. But of course, you would have noted from the preceding slide where we were describing the PK/PD targets that are associated with better clinical outcomes, that in each of those, the MIC, so the minimum inhibitory concentration, which is a measure of susceptibility of the pathogen to that antimicrobial, was the denominator in each of those PK/PD indexes. And so that means that although we can consider the altered pharmacokinetics, we do need to also be aware of what the pathogen is and what the likely or alternatively possible what the actual MIC is. Because if it's a highly susceptible pathogen causing the infection and we have just a normal reasonable dose of drug, it's highly unlikely that our dosing is going to be inappropriate. But when it gets closer to a higher MIC, which is closer to the MIC breakpoint, that's when we tend to run into problems with drug dosing appropriateness and the need for personalizing the dose to the individual scenario of the patient, the altered pharmacokinetics, as well as the MIC of the pathogen becomes more important. So we've looked at this, this topic of altered pharmacokinetics just in the context of just a broad schematic. What about looking at some of the pharmacokinetic data to describe how different some of these pharmacokinetic parameters can be between a critically ill patient, so a patient in the ICU, versus a healthy volunteer? On this slide here, which is from a review paper that we did back in 2011 or so, you can see that we've got a range of different drugs there, some beta-lactams, glycopeptides, and fusidic acid, describing a change in drug clearance in ICU patients and a change in drug volume distribution in ICU patients where that was reported. Essentially, you can see there are substantially higher values which are reported in ICU patients. And so this, of course, means that there is a higher drug clearance and a higher volume of distribution, and this can lead to dramatically lower concentrations, particularly earlier in the course of therapy for patients, demonstrating the importance of using ICU-specific dosing, and in particular, dosing appropriate to the individual ICU patient, as opposed to product information dosing, which most commonly is based on data from healthy volunteers. So let's talk a little bit about beta-lactam pharmacokinetic variability in ICU patients. Why beta-lactams? Because, of course, they're the most commonly used drug class that we use in all of medicine, really. This is data from a study called the DALI study. So the DALI study stands for Defining Antibiotic Levels in Intensive Care Unit Patients. And this was a multi-center pharmacokinetic point prevalence study, which was performed in 68 intensive care units in 10 European countries. This was a study that we were very proud to coordinate from Australia with the support of the European Society of Intensive Care Medicine. Here on this graphic, we have 8 different beta-lactam antibiotics representing, I think it's about 375 patients worth of data, with concentration on the y-axis, and you'll note that that's not a linear scale, that's a log2 scale. Essentially, the main point to take away from this is that drug exposures, trough concentrations, are highly variable in critically ill patients. And here we can see up to 500-fold variability of beta-lactam concentrations. So if you think about what the contemporary approach to dosing is that basically for piperacillin, we use pretty much a standard dose in all patients. But the point to note is you don't get a standard exposure or a consistent exposure in all of those patients. And as you can see there's up to 500-fold variability in exposure, with some of those exposures being very, very low, well below what we would consider to be even an acceptable exposure of drug. And so this heightens our understanding of what happens with a one-dose-fits-all approach to dosing and makes us realize that we potentially should be more selective in our dosing approaches to individual patients. So I hope this slide's projecting properly. This is one of the tables from that antimicrobial TDM paper, the position paper that I referred to earlier. And essentially what this does for all of the different drug classes is it defines what the PK/PD index is. So is it a drug which requires a high peak concentration to MIC ratio? So that would be, of course, an aminoglycoside. Is it a drug which is more related to the time for which antimicrobial concentrations are maintained above the MIC, which should be a time-dependent drug like the beta-lactams? Or is it an AUC-MIC drug, where the AUC stands for the area under the concentration time curve, and that's essentially an integration of the area under a concentration time curve. So it's a measure of the total exposure. It also describes the PK/PD targets for efficacy based on preclinical studies versus what's been demonstrated in clinical studies, and also the threshold associated with drug toxicity as well. And so this is very useful because what it helps define is the kind of exposures which one should be aiming for when dosing drugs in critically ill patients in particular. Now, where we don't have therapeutic drug monitoring for a drug, this provides less value because you don't have a concentration measurement which you can directly compare with the PK/PD target. But what it does do is it gives you a sense about the kind of exposures that have been defined relative to what may have been described in healthy volunteer pharmacokinetic studies, so you can see what order of magnitude higher dosing is required. And so if I could give an example of this in the context of ciprofloxacin. So ciprofloxacin was a drug that was initially launched at a dose of 200 milligrams every 12 hours or every 8 hours back in the late 1980s, early 1990s. And it was quickly observed that resistance was emerging to this drug in some patients, and that some patients weren't necessarily benefiting from that drug. And so a group in Hartford, Connecticut in the USA performed an observational pharmacokinetic study where they also collected patient outcome data using drug exposure combined with MIC data that was available, and then comparing those results with patient outcome. They were able to show that a much higher area under the concentration time curve relative to what was achievable with low 200 milligram BD or 12-hourly, 200 milligram 8-hourly dosing was able to achieve. And they demonstrated that a dose closer to 400 milligrams every 8 hours, so double at what was in the product information, would be required in most patients to achieve a target AUC-MIC of 125 for particularly for Pseudomonas infections. And so, yeah, that's a classical example of how a post-marketing study has been able to redefine dosing requirements for a drug. And that kind of information is what is included in that table. Now, I want to talk just very briefly on pharmacodynamics in the context of susceptibility patterns. Now, I referred to the importance of MIC before, but I didn't describe its importance in the context of critically ill patients. And that's because, you know, the intensive care unit is a highly protected area whereby you can have patients that have prolonged lengths of stay. They're more likely to have multiple courses of antimicrobials because of multiple infections that they may develop over the course of their stay. And in doing so, they're more likely to have, of course, more resistance or less susceptible organisms causing infection. And this is something which has been described in a number of epidemiological studies, whereby in this specific example here, which is a German surveillance study of carbapenem MICs, that in critically ill patients versus ward-based patients, that ICU patients or critically ill patients had MICs for their pathogens which were 2 to 3 dilutions higher than was the case for ward-based patients. So that's important because that essentially means that not only do we have altered pharmacokinetics to deal with, but we also have altered pathogen susceptibility relative to what we would see in a ward environment. So if we bring together this altered pharmacokinetics and this altered pharmacodynamics, and we talk about, well, in a large cohort of patients that we have data for, what is the effect then of current dosing on the ability to achieve those drug concentrations and exposures which are associated with better patient outcomes? So again, this is data from the DALI study, 8 different beta-lactam antibiotics, so over 350 patients worth of data. And this time on the y-axis, instead of concentration, we've got a PK/PD ratio, which is what I would consider to be quite a conservative target of 50% time above MIC. So that the dose, it's the concentration of the drug needed to exceed the MIC for at least half of the dosing interval, which is an exposure supported by in vitro studies. Essentially what this study found is that about 16% of patients didn't achieve that target. So that's nearly 1 in 5, 1 in 6 patients. And then they were 3 times more likely to fail treatment. So that's quite a significant proportion of patients that aren't getting appropriate exposures of drug, and there is data from this study showing they're failing therapy. In terms of what's more likely to be an appropriate exposure, about 45% of patients didn't achieve that more aggressive exposure, which is closer to those PK/PD targets which were defined in the position paper. So that demonstrates a lot of where we have to go. So there's a lot of background there, but I think that's all very important. So now I want to talk about augmented renal clearance. So augmented renal clearance is defined as a creatinine clearance greater than 130 ml per minute. Now, this was something which we defined back in about 2010 or 2011 and was the subject of the PhD of an intensive care physician called Andrew Udy, who did some fantastic work in this area. This is one of the studies that we put together trying to demonstrate the effect of augmented renal clearance on drug exposure. So on the x-axis, there's creatinine clearance, which was a measured urinary creatinine clearance. And on the y-axis, there's a trough concentration to MIC ratio. Now, as you'd expect, as renal function increases, as you start to see a much higher creatinine clearance, you will see lower drug exposures. And that's something which, of course, is well known for beta-lactam antibiotics, which are almost exclusively renally cleared. And so this is data from 51 critically ill patients who are receiving a beta-lactam antibiotic as part of the therapeutic drug monitoring program that we have at our hospital for beta-lactams. But what's particularly interesting here, and unfortunately it's not coming out very clearly in this graphic, is that some of the patients had creatinine clearances greater than 200 and 250 mil per minute. Now, for us as in the audience here, I'd like to think of us all as relatively well and fit people. We would probably have a creatinine clearance somewhere between 100 and 150 mil per minute for younger people that may be listening. But some of these patients, because of that inflammatory process that develops in critically ill patients in response to some sort of insult, like infection or trauma, they can develop much higher drug clearances. And that's certainly what we're seeing here. Creatinine clearances as high as 300 mil per minute, and that was associated with very low drug concentrations. Note that that's a log 10 scale on the y-axis. What are the consequences of that then for patient outcome? Because that's obviously quite important. This is an observational study from Jan de Waele's group, who works at Ghent University Hospital in Belgium, and essentially comparing the outcomes for patients with augmented renal clearance on the right-hand column versus the middle column for those patients that did not develop augmented renal clearance. Essentially, patients who developed augmented renal clearance had a 27% likelihood of failure versus 13% in the non-augmented renal clearance patients. So this is a study of only 130 patients or so, but essentially, it's quite powerful in demonstrating what the high failure rate is associated with augmented renal clearance, in all likelihood because of low drug concentrations. What about a stronger, more robust trial? Well, this is a really important study, a very sad study in many ways about doropenem. Now, doropenem is supposed to be a microbiologically superior carbapenem to all of the other carbapenems, and was developed by Johnson & Johnson as a drug which is able to provide enhanced outcomes for patients. And so Johnson & Johnson subjected it to a phase 3 multi-center double-blinded randomized controlled trial for patients with ventilator-associated pneumonia, and compared a fixed 7-day course of doropenem versus a fixed 10-day course of imipenem. Essentially, halfway through the study, the Data Safety Monitoring Board had to terminate the study because of patients in the doropenem group, so the microbiologically superior doropenem group, were more likely to fail treatment. Now, when they did some sub-analyses to try and investigate why that was the case, there was a dramatically increased likelihood of patients that had a creatinine clearance greater than 150 mil per minute that were likely to fail treatment in the doropenem group versus the imipenem group, raising questions about, was the dosing regimen that was put forward in this study appropriate given what the likelihood of patients in the ICU developing augmented renal clearance was? And clearly the answer here was no. And we subsequently did a dosing simulation study afterwards to demonstrate that indeed that dosing regimen which they had used would have been insufficient and is most likely the reason for why doropenem has largely been lost from the international market. So, it's a very important consideration even in drug development. What about renal replacement therapy? Well, this is some data that I wanted to present to you from the SMART study. The SMART study stands for Sampling Antibiotics, Antimicrobials and Renal Replacement Therapy. This is a multi-center pharmacokinetic study conducted in about 29 intensive care units around the world. I think it was about 14 countries that participated in this. Again, another study that we're very proud to have led. And on this slide here, there's just some demographic data, which is pretty consistent with what you would expect to see for patients with renal replacement therapy. Something which was particularly interesting in that first table there is a parameter described as ETRCL, which is essentially the estimated total renal clearance for these patients, which is trying to find a surrogate for creatinine clearance. And typically when I would be trying to establish or calculate a dose which may be appropriate for patients with renal replacement therapy, I tend to guess a dose of, a creatinine clearance of 30 ml per minute as a substitute. But what was found in this study here is that it's actually closer to 50 ml per minute in terms of an average creatinine clearance equivalent that is caused by the presence of renal replacement therapy. So I think that's a really important thing to consider. The table on the right just essentially shows the vast range of dosing regimens that we used in these patients. What that demonstrates is the dramatic uncertainty that people have about what dose of drug that they should be using in different forms of renal replacement therapy. If we look at the pharmacokinetic outcomes associated with this study, is that, again, highly variable pharmacokinetic data for meropenem on the top left, piperacillin top right, tazobactam bottom left, and then vancomycin bottom right, and that many patients don't achieve what we'd consider to be a minimum therapeutic target, and many patients also have excessively high concentrations where it's likely that they are at risk of drug toxicities. There was also some relationships associated with drug exposure and patient survival as well described in this study. So this is an important paper published in 2020 in Clinical Infectious Diseases. What about ECMO? So the main concern with ECMO really is this picture on the top right corner of the slide. So this is the oxygenator and all of the tubing which connects the bloodstream to this. It constitutes a large surface area, and as many of you will know, there's a lot of literature going back 5 decades describing the adsorption or the sticking of some drugs to different types of plastics. And that's really what the concern is with ECMO. And some of the in vitro studies have demonstrated that, in particular, highly protein-bound drugs and drugs that are lipophilic, which are most likely to be at risk of binding to the oxygenator and therefore to have much lower drug concentrations. But really, other than that, it's probably okay, and you just dose according to what the patient's organ function is. One study which I think demonstrates that quite nicely is this pharmacokinetic study, which is a collaborative undertaking between our group and Fabio Tacconi's group in Erasme Hospital in Belgium, whereby we combine 2 cohorts of patients receiving meropenem, patients that received meropenem with ECMO and those that were critically ill patients that didn't have an ECMO requirement. And we tried to match them as best as we could. Then we subjected to a formal pharmacokinetic modelling process and essentially found that the most important factors associated with the need for altered dosing was the presence of renal replacement therapy. And if the patient didn't require renal replacement therapy, then it was what their creatinine clearance was. ECMO wasn't considered to be a statistically significant variable at all. And so this is one piece of data, and there's a number of studies which have come out since for other drugs which have demonstrated that dose adjustment for beta-lactams, generally speaking, in the context of ECMO, don't need to be done because of the presence of ECMO. It should be based on renal function estimates or drug clearance estimates on their own. And so there is some interesting data which is coming out from the ASAP ECMO study. We've now got 3 papers which have been published on this, with more to follow. And essentially that antimicrobial data which has been published so far, which constitutes data from over 100 patients receiving ECMO, demonstrates that for drugs which have low protein binding, that are more hydrophilic as opposed to lipophilic, don't need to be dose adjusted because of the presence of ECMO. So what conclusions can we make based on all of this data? Well, firstly, that the key opinion leaders in our area tend to agree with us that pharmacokinetic, pharmacodynamic-based optimization of antimicrobial therapy is very important. So this is one of the recommendations from the Infectious Diseases Society of America and the American Thoracic Society clinical practice guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. And this was very much a key recommendation that they provided, that although the quality of evidence, as I've already shown you, is quite low because a lot of the data comes from observational studies, that the consistency of the data supporting the need to achieve a therapeutic exposure of drug suggests that a recommendation was appropriate to be made for antibiotic dosing to be determined using PK/PD data. So essentially going through all of the processes that we've been talking about today and using each of those considerations. Now, in the bottom right-hand corner of this slide, you'll see it's a very small table, but essentially these are the recommended empiric doses for various antimicrobials, which take into account each of those different factors that we've been talking about today. That take into account the potential for significant augmented renal clearance, the potential for dramatically altered volumes of distribution. And so, those dosing regimens for the beta-lactams as well as quinolones and aminoglycosides are described there. There's also data that exists for other drugs as well, which we'll talk about on this next slide. Because one of the important things for us to be thinking about is that, all right, so we can understand, okay, that dosing needs are different, but how do we actually go about using a different dose? Well, a lot of it depends on the resources that are available to you. Of course, if you're a resource poor setting, then there's only so much you can do in terms of the kind of interventions you can make. But something you can do is you can use dosing regimens using the same dose of antimicrobial, same daily dose, but apply that to, use that dose in line with what the PK/PD characteristics of the drug are. And so I would call these unit level interventions, whereby essentially for that class of drug, you use that approach to dosing for all of the patients that you have. So one example would be prolonged infusion of beta-lactams, whereby instead of giving beta-lactams as a 30-minute infusion, as would be recommended by most product informations, you would give it as an infusion which runs for at least half of the dosing interval, if not as a continuous infusion. And of course, this has been a topic of the BLING research program, which I'd be happy to talk about a little bit later on. But prolonged infusion of beta-lactams has now been endorsed by the Surviving Sepsis campaign guidelines, which were released in October of this year, as one of the interventions which is recommended for application in patients with sepsis. So prolonged infusion of beta-lactams, it doesn't cost any more. It's something which is a very applicable intervention. Another is extended interval aminoglycosides. So this is, instead of giving aminoglycosides as the traditional 3 times daily dosing, as I have seen does still occur in some countries around the world, surprisingly, and has come through in some surveys that is done, that you just convert that overall daily dose, which you would usually split into 3 doses, into a single dose and give that once a day. That's certainly far better for achieving a higher Cmax, a higher peak concentration, and also results in lower trough concentrations, which therefore minimize the likelihood of drug toxicity. And systematic reviews and meta-analyses consistently demonstrate that that is by far the most appropriate way to use aminoglycosides. The second option you could do, again, this doesn't need a lot of resources, is to apply dosing nomograms, which have been developed in critically ill patients, to choose a dose which is specific for the patient in front of you. So commonly we would do this with aminoglycosides with a weight-based dose, so a milligram per kilo based dose, also done with drugs like ticaplanin as well. Vancomycin also has weight-based loading doses for example, as well. But you can also use creatinine clearance-based dosing for renally cleared drugs. And so there are nomograms for creatinine clearance-based dosing of vancomycin, including creatinine clearances up to as high as 250 ml per minute. And there are also nomograms for beta-lactams, including meropenem, but also piperacillin and tazobactam, whereby essentially you're just reading off a sheet of paper what the appropriate dose is based on the patient's measured renal function. Where increasing resources are required, this is when you could apply things such as dosing software, whereby essentially this has a pharmacokinetic model embedded in a piece of software which has an easily usable interface, and then you can put in information about the patient. It'll then run that information through the dosing algorithm and provide you with a recommended dose. And of course, the final option is therapeutic drug monitoring, which I don't want to go into too much detail other than to say that for, where it is available, definitely should be used, because it's the only way of ensuring that all patients achieve a therapeutic exposure. Because with all of those other interventions, although they are better than just standard dosing, this approach is the only way that you can ensure that take out the effect of pharmacokinetic variability, which impairs the others. Almost all drug classes now have had studies published on therapeutic drug monitoring application of these. And so it is something which is available in only small parts around the world for all drugs, but it is something which I think we're going to learn a lot more about in the years to come. So I'll conclude there by just reminding you that there is a clear concentration effect relationship for antibiotics. And although many patients can be administered a typical dose, if it is a patient which has rather extreme pharmacokinetics, then you won't achieve those concentrations that are associated with the higher likelihood of achieving an appropriate exposure for that patient. And I hope that this extensive description about pharmacokinetics can assist you as you try to calculate what the likely altered pharmacokinetics are in each individual patient that you treat, and therefore can ensure that you are more likely to choose a dose which is specific for that individual's requirements. So I'm happy to conclude there and then pass over back to my wonderful chairs for this evening.
Thank you so much, Dr. Jason. At the outset, I would like to thank you for the wonderful presentation. Actually, I had made 4 points which I wanted you to address. One of them was augmented renal clearance. The second was about PKPD dosing and modification of dose in ECMO. And third was about continuous infusion of beta-lactams. And fourth was about therapeutic drug monitoring. I think most of them we have covered in your talk. So I think that's wonderful that, whatever we wanted to get out of your presentation, you have addressed very nicely. And I think that's the real reason why we should have a clinical pharmacist in our ICU rounds. I feel it's essential part of critical care. I have been worked with critical care pharmacists for the last 6 years before, and I really see changes happening in patient outcome when we take an advice from clinical pharmacist and use interventions advised by them, especially for ECMO patients or patients who are having dialysis. Just wanted to ask one more point, like what's your opinion about using nebulized antibiotics? Like when you use some of the patients with ventilator-associated pneumonias, we tend to use nebulized cholesterol or aminoglycosides. So I just wanted to take your point of view on that part.
So that's a very difficult question. There's some guidelines that came out from the European Society of, ESCMID, European Society of Clinical Microbiology and Infectious Diseases, which essentially recommended against use of nebulized antimicrobials. And that was done in the context of the fact that essentially there's not enough data to ensure that there's consistent delivery of drug to the likely site of infection. And one of the things that's clear about inappropriate settings for a nebulizer is that it's just going to cause impaction, whereby either the drug just sticks to the nebulizer or it just goes onto the plastic, but essentially doesn't diffuse adequately through the lungs and into the lower lungs in particular. But that being said, the ATS-IDSA guidelines did have a weak recommendation that they could be used in the context of resistant infections as well. And so different people can come to different conclusions. In our practice, in our hospital, we're very fortunate that we don't have significant problems with antimicrobial resistance. But where there is a patient that has a severe pneumonia caused by a pathogen which has a very bad resistance profile, and whereby we have to use a drug which we're concerned is that it won't penetrate effectively into the lungs, such as colistin or aminoglycosides, that's the only time whereby we would try to use that. Sometimes that might be after a couple of days of IV therapy and noticing that we're not seeing any improvement. And as you know, as the situation becomes more critical for patients, sometimes you may reach for different therapies. That tends to be the scenario that we use it. It's not common, but that's partly because of the way that the resistance patterns in Australia are.
And one more point I wanted to ask, like if in case you're using a continuous infusion of beta-lactams, and if the patient is on intermittent dialysis, like most commonly in India, the more common practice is to use intermittent dialysis as compared to CVVSD in Western practice. So if the patient is on infusion of carbapenem and we are using a dialysis intermittently, well, how do you recommend dosing of carbapenem in those patients?
So a lot of it depends on the carbapenem dose that you're using, because you will get pretty good clearance of the drug with intermittent hemodialysis, but that only runs for 3 or 4 hours a day. So if you have a low dose of drug being continuously infused, and so I'm saying, say, 500 milligrams over the course of the day, like that would be a very low dose, even though that would be okay to be given post-dialysis and dialysis ward. Continuous infusion is a bit different. You would end up with low drug concentrations. Because the infusion is so slow, it would take a long time for that concentration to then become therapeutic again. And so my recommendation would be that you could either give a little bolus post-dose, post-renal replacement therapy, or alternatively, you could just use a higher renal continuous infusion dose on dialysis days. Maybe you would use 500 milligrams or a gram on non-dialysis days, and then a gram or 1,500 milligrams, meropenem I'm talking about here, on dialysis days, as an example.
So we used to use around 750 milligram post-dialysis in such patient. Will you recommend the same? Like on the day of dialysis, we used to give around 500 to 750 milligram post-dialysis. That's the dose.
Yep.
Because we don't have drug monitoring available here very easily. So that's what.
Yeah. So if we're not talking about continuous infusions, then I absolutely agree with you that approach is right. I think that you don't need any more than that kind of dose.
And one last thing about vancomycin. Do you still use vancomycin in your practice? So because most of the European they stopped using vancomycin. I just learned 2 days back that they're not using vancomycin anymore in Europe because of the monitoring problem and probably the availability also. Because they have better drugs. They use ticopenin more than vancomycin. So do you use vancomycin in your practice?
So we do use vancomycin, but we don't have much MRSA. So we don't use it as much as we did perhaps 15 years ago. But vancomycin is still widely used in the States, in Canada. It's not used much in the UK because they favour ticoplanin. It is used in different parts of Europe, although linezolid has become a little bit more popular since becoming off patent. But still, I think vancomycin is still quite widely used. It is by far the most studied antimicrobial and remains to be the case. And almost all studies ended up being the same kind of thing too, how to dose it. It's a tough drug, ironically.
Because I remember we used to use trough levels to monitor drug levels. And I have used nearly maybe 4 grams in a day for a young patient who was having augmented clearance. So do you come across the same problem in your ICUs? Augmented clearance?
We've used doses as high as 7 grams as a continuous infusion in the patient. That's very rare. It's not uncommon at all to end up using 5 grams per day as a continuous infusion in neurotrauma patients, young males that are perhaps, under 40 years of age and that don't have kidney dysfunction. That's a very common scenario. So we tend to use intermittent dosing, like 12-hourly dosing of vancomycin, but where it's clear that a patient has a higher drug dosing requirement, then we'll convert to continuous infusion. But yeah, high doses in augmented renal clearance, very well correlated with vancomycin.
And do you use trough levels or you use the MOC and area under curve strategy for the dosing of the vancomycin?
So we're quite comfortable still with trough level monitoring. I do believe that where there is a patient that has a severe MRSA infection, that there is an advantage to AUC monitoring from a safety perspective, and we would look to try and apply that. But that would only be in cases whereby the patient has a severe infection, whereby we're targeting very high drug exposures and making sure that we're also, in doing so, trying to minimize the likelihood of nephrotoxicity.
Thank you so much for your insights. Do you have any more time for questions, madam?
We can have 2 minutes.
Okay. Audience can unmute or put the questions in the chat box.
I don't see any questions, but I have a question. Jason, what is the approach different for acute kidney injury and chronic kidney disease about adjustment of antibiotic dosing?
Almost no difference at all, just purely based on what is the person's creatinine clearance on that specific day for a renally cleared drug, and then to dose for that. It just happens to be that if they have chronic kidney disease and not acute on chronic kidney disease, that you can use that same dose each day. Whereas if it's acute kidney injury, because of the changes that you're likely to see each day, you might have to modulate that dose each day. Whether or not, it depends on the level of sickness severity about the kind of dose that may be given on day one. Maybe an acute kidney injury patient, they're more likely to have an altered volume of distribution as well. And so you might give that patient a slightly higher dose on the first day. But otherwise, I tend to base very much based on what I estimate or measure the renal function to be in that patient if we're talking about a renally cleared drug.
I think we are running out of time, probably. So thank you, Dr. Jason, for your wonderful presentation and also patiently answering all our questions. From the outset, from all of us, very well done, and probably look forward for further association from this side.
Thanks very much for the opportunity to talk. I have an apology to make. I was going to put a picture of the T20 World Champions up on my screen just to demonstrate my love for cricket, because my Indian friends often will do the same when they've just beaten us in a home test in Australia or something similar. So it would have been a nice opportunity to do that because we don't have many wins at the moment, the Australians.
Thank you.
All right, thank you.
Thank you, Jason.
My pleasure. Happy Antimicrobial Awareness Week, everyone.